Hello everyone, I'm Dr. Beya Aisha, an anesthesiology and intensive care doctor, and I work at Hospital Military of Tunis. I am honored to be with you this afternoon, thanks to the trust to Professor FERJANI. I declare that I have no conflicts of interest. My task is to respond to the following question. Should we care about hemodynamic monitoring in the context of this session? Let's start by defining the context. Heart failure is a common disease. Thanks to an understanding of the pathophysiological mechanisms, the diagnostic concept of a single clinical entity has evolved into the notion of acute heart failure syndromes, including several diagnostic frameworks, from acute decompensated heart failure to acute respiratory distress on cardiogenic pulmonary edema, or even cardiogenic shock, which is not the most frequently but the most serious. Although clinical signs, diagnosis, treatment may vary, hemodynamic management follows a common rationale. Let's consider the example of a patient arriving at your emergency room department in this scenario, acute coronary syndrome complicated by acute pulmonary edema and cardiogenic shock. The first mechanism involves left ventricular systolic dysfunction, leading to reduced cardiac output and arterial hypotension. The second mechanism is left ventricular diastolic dysfunction, causing increased left ventricular filling pressures. And the third one is linked to sepsis-like systemic inflammation. It is the combination of these three mechanisms that contributed to reduced tissue perfusion and the development of multi-organ failure syndrome in the context of cardiogenic shock following a myocardial infarction. Understanding these mechanisms guides us in defining our therapeutic goals, which are increasing systemic vascular resistance, increasing cardiac output, and achieving recommended oxygen levels. But why is monitoring essential? The first reason is this: just as you would never prescribe an antihypertensive drug without monitoring blood pressure, and just as you would never implant a pacemaker without an electrocardiogram recording, vasopressor and fluids fall into the category of medications, so it's imperative not to use them blindly. The second reason is that it's recommended to do so by experts. In the context of cardiogenic shock, they have defined therapeutic targets to monitor, and I repositioned it in this table. Let's emphasize the importance of clinical monitoring. A neurological examination, Mottling score, and cardiac auscultation helped us identify the clinical scenario and offer insights into specific parameters. A lot of studies have explored the link between cardiac output and clinical indicators. In this context of shock, the authors investigated the relationship between 19 clinical parameters and changes in cardiac output, and their findings led them to conclude that clinical signs cannot consistently indicate whether cardiac output is high or low. So the third reason for the necessity of hemodynamic monitoring is that physical examination can be a trigger, but not a substitute for hemodynamic evaluation. If we combine clinical assessment with invasive arterial pressure measurement, can we optimize our ability to evaluate cardiac output? The answer is yes and no. Research has indicated that the correlation is fairly reliable for patients not receiving vasopressors, but not for those who require vasopressors. So this leads us to the fourth. Pulse pressure and systolic arterial pressure were unable to detect the changes in cardiac output induced by norepinephrine. And what about cardiac ultrasounds? Experts suggest that when further hemodynamic assessment is needed, echocardiography is the preferred modality for assessing the type of shock as opposed to more invasive technologies. It is valuable for assessing both systolic and diastolic function. And combining pulmonary and cardiac ultrasound enables a diagnosis of cardiogenic pulmonary edema and facilitates this ongoing monitoring of treatment strategies. This can be initiated as soon as possible, even in the emergency room. This is our current practice. But in the future, we will also monitor venous congestion in deeper organs using Dopplers, especially in the hepatic and renal systems. And as we are aware, congestion and fluid overload can have life-threatening consequences. Therefore, evaluating both perfusion and congestion guides treatment decisions for healthcare teams, but further research is needed to determine which ultrasonographic techniques and clinical protocols provide the most useful information for individual patients. This slide summarizes our discussion. In heart failure cases, we start with initial monitoring to guide the initial therapeutic steps, which we must reassess. If the patient does not respond to treatments, how many echocardiography should we repeat? It is at this stage that we consider more invasive monitoring. In cases of refractory cardiogenic shock, experts advise utilizing invasive and continuous hemodynamic monitoring. Two validated and recommended tools in this context are pulmonary catheter, pulmonary artery catheter, or PAC, and transpulmonary thermodilution. And the fifth reason for the necessity of hemodynamic monitoring is that in the most severe patients, we will address the following questions as many times as required. What about cardiac output? Should fluid be administered or not be administered? What about LV contractility, and how is the afterload of the right ventricle? PICO is a cardiac output monitor that combines pulse contour analysis and transpulmonary thermodilution techniques. It enables continuous monitoring of various hemodynamic parameters, cardiac output of course, as well as the management of our therapeutic intervention. For instance, let's consider extravascular lung water. It's 3 a.m., your patient intubated and mechanically ventilated, receiving high doses of vasopressors, experience hypotension. We perform a PICO assessment. If we have an extravascular lung water around 7, we can consider a mini fluid challenge. If the extravascular lung water is around 17, we will avoid giving fluids and opt for vasopressors. Concerning the Swan-Ganz catheter, is positioned at the level of the pulmonary artery, and it offers reliable assessment, bedside availability, continuous monitoring, and comprehensive hemodynamic approach. This allows for continuous monitoring of cardiac output, central venous oxygen saturation, various parameters related to cellular oximetry, like oxygen extraction or arterial oxygen content. But most importantly, it serves as a sixth reason for the necessity of hemodynamic monitoring, assessment of right ventricular function and its afterload. But there are significant drawbacks, including safety concerns, requires skills to implant, difficult interpretation, revealed by echocardiography, no proven benefits. So its use is reserved for trained teams and its indications are limited. Diagnostic uncertainty, therapeutic failure, biventricular dysfunction, or acute respiratory distress syndrome. Before we conclude, let's touch briefly on non-invasive methods such as ClearSight, for example, which allows continuous assessment. Experts have indicated that these methods may not be suitable for critically ill ICU patients, and as you can see, there's only one study in this specific context, including only 10 patients, and it has revealed notable error rates in this patient group. So non-invasive methods for continuous cardiac output, we need to await further insights in the future. To conclude, the ideal monitor does not exist. The various European recommendations are clear on this matter. There is no optimal hemodynamic monitoring method for patients in cardiogenic shock, and sequential assessment of the hemodynamic status in this patient is suggested, adapting to the severity of the clinical scenario. In our intensive care, we have a structured approach. We start by assessing patients and determining their clinical condition. Then we initiate basic monitoring, particularly for non-shocked patients. Echocardiography is a standard procedure for all cases of heart failure. It will allow us to refine the diagnosis of the clinical scenario and also provide us with information regarding the patient's left ventricular ejection fraction, because we cannot manage heart failure with a 30% LVEF in the same way as heart failure with preserved LVEF. In situations with associated shock, we consider using PICO or EV-MIL. Finally, we reserve the use of a Swan-Ganz catheter for specific and limited indications, typically when we need to assess right heart function in cases involving the right heart. What should we remember? For complex cases For complete cases of acute heart failure, receiving vasoactive drugs, cardiac output is mandatory. Every patient, echocardiography for every patient. Transpulmonary thermodilation systems such as PICO for real-time measurement of cardiac output in critical care patients, and PAC is the only tool for the precise and direct measurement of pulmonary vascular resistance. So should we care about hemodynamic monitoring? Of course we have to do it, but we have to personalize which patients, which clinical scenario, which evolution, which available systems, and particularly what do we know to do. Thanks for your interest.